I want to welcome you to our exciting workshop today on envisioning the future of patient and public engagement in research. We're here today really to explore the transformative potential of engagement in shaping research and ultimately healthcare. For me, engagement is not merely a buzzword, but it really represents a paradigm shift that really aims to elevate the invaluable voices of patients and the public to the forefront of research and decision-making. So today, let's dream, let's innovate, and let's collectively sketch the future where engagement isn't just an add-on, but a fundamental guiding principle that moves us towards compassion, effective, and a responsive healthcare system. My name is Yvonne Pelling, and I'm with PASSERELLE. I am the Patient and Public Engagement Lead, and with me today I have two amazing people.
Hi, I'm Audrey L'Espérance. I'm Assistant Professor of Health and Social Services Management at INAP in Montreal. I'm really happy to be here talking about patient engagement. I do agree with you, Yvonne, that it's a paradigm shift.
Oh, and hi. Thank you. First of all, thank you, Yvonne, for putting all of this together. This is fantastic topics, and we're really looking forward to hearing from all of you. And thank you already for the tech support, because we've had a number of things to get set up before getting started. My name is Annie Leblanc. I'm a faculty at Laval University in Quebec City, and I'm also the nominated PI and scientific lead of PASSERELLE, the Sport National Training Entity, and we'll tell you a little bit more about it in a few minutes. So, Yvonne, back to you, I think.
Our online facilitators.
Oh, yes. Oh, thank you. And I had one job. And just so you know that we have people joining us online through the Zoom apps, and welcome everyone who's joining us online. You will notice that you also have two facilitators to help you with your different questions and also to discuss with during our different activities. So we have Émilie Grenier, who's our lead coordinator at PASSERELLE, who's been involved with sport initiatives for 6 or 7 years now. And we also have Roxane Bouchard, who's one of our master level students, who's there to chat with you. And please feel free, either online or here, but if you'd rather ask questions in French rather than in English, would be more than welcome to answer. Ça va nous faire vraiment un très grand plaisir. And we can act as a translator and facilitator in both French and English. So welcome, everyone.
So I'd just like to start with a land acknowledgement, and I think... So PASSERELLE recognizes our central office is situated on the traditional unceded territory of the Huron-Wendat people, colonially known as Quebec City. In the spirit of respect and reconciliation, we extend our gratitude to the Huron-Wendat Nation for their stewardship of this land. As we work towards a research future that's more inclusive and puts patients and the public at the center, let us also make a commitment to educating ourselves about the rich Indigenous heritage that's helped shape our collective journey. Let us move forward together by embracing the wisdom of the past to create a better tomorrow. And I'm going to just pass it over to Annie.
Thank you. And I'm going to move like this because I know we have online people, but for those who know me, I don't like to be tied to a microphone, but I will try to. So before we get started in all of your activities, we wanted to take a few minutes and talk to you about these new initiatives. And maybe some of you have heard before of PASSERELLE, of the Sport National Training Entity. No? Oh, see, perfect. That's why we're here. So PASSERELLE is one of the latest sport entities with the families. I'm sorry. And it was really designed as a pan-Canadian hub, a network of networks. So our role is really to take from all of our lesson learned, all of the work that many of you have contributed to over the years, and come together with those lesson learns to offer a wide area of activities specific to capacity building. So through our different activities and initiatives, we're still brand new. So as you know, it takes a little bit of time to get up and running, but it is really dedicated to everyone. So PASSERELLE is of service for patients, for public, for community members, their loved ones. We're there for researcher, trainees, students, for academic leader researchers, but also for organizations, research groups that would want to learn more about patient engagement and patient-oriented research. And what do we offer? Well, we offer a number of services and activities. Some of them are already up and going. Some others are being co-built with different spore entities as we speak, but that really focus on our capacity as a group to learn, to share together, to empower each other so that, again, all together we can make a difference. And the type of activities that we offer in service are first tailored to learning. So through PASSERELLE, you have access to a central repository of all the POR training that has occurred, patient engagement training that has occurred over the past decade. So we conducted this huge scan where every organizations that had activities to offer, we now have it centralized. So it's really a way for us to bring everything together so that you don't have to go and knock on everyone's door to try and find the right things that works for you. And everything is to almost everything is offered for free. Of course, there's some things that do have a bit of fees, but that's not our fault. It's the way those programs are designed. But generally, what you can find is you can either have self-directed activities, and we do now have this learning platform that you can join. And not only can you take those activities, but you can also keep track of them. You can keep track of those activities, you can earn certification, you can earn badge, you can see what other platforms and other training entities have to offer as well that goes beyond patient engagement and patient-oriented research. So you've got access to a number of activities. Within that space, we also have more tailored curriculum. So for those that are just joining patient engagement and patient-oriented research, we're working toward a centralized POR fundamentals. But from there, many of you that I see are already expert in the field. So we're also working to make more advanced curriculums and more advanced pathways. And that's the last thing that we have to offer is that when we work with our different knowledge users and partners, they were saying, well, you know, learning is one thing, but what we need is to learn together, and we need to network, and we need to be able to be there and mentor each other and learn from more experienced people. So with many groups, we're now working to design learning pathways. Those pathways are within a specific field or within a specific context so that not only are you learning, but you're learning with your peers, with the people involved in that field, with the organizations that are going to make a difference in that field. So these are the different activities that we can offer. We also aim to create a community and try to bring all of us together. I think it was shared earlier today about how do we get to know each other, how do we get to learn from each other. So we do have a different set of tools and resources, again, centralizing everything that we've learned this past decade in one place so that you can have access to that. But we are also here, as we are today, hoping to facilitate events and conferences and activities that favor patient engagement. So not only do we do those research activities, but as a group, if you wanted to, let's say, okay, how do I move my organization? How do I move my institution more toward POR? Can we create some kind of tailored events for them to get them to learn more about what we do and how we do this? We can help you facilitate that, and we provide the funding to do so. Also, we're there to facilitate networkings and mentoring. It's been hard with the pandemic behind us, but we're really trying to see how we can initiate more of these activities so that you get to meet your peers, you get to meet those involved in different aspects of it. We're working on a number of programs, and I don't want to open up to everything that we're doing, but one of the things, among others, that Yvonne just started working with two of our partners is how do we as patients move to become mentors? And what does that role of patient mentors would look like to our trainees, to others in the field? So these are the kind of activities that we're promoting through our work. And lastly, in that Empower sections, we're really working toward offering consultation and guidance to organizations and groups that would want to be involved in POR but don't know where to start. What is that first step? What does it look like? So that we as a research group, as an organization, can onboard. So working from different patient engagement to patient-oriented research activities, really getting them to help those different communities to provide these onboarding process. We all know what it is, why it is important, but how to. And you're probably the first, and we'll learn from you today as well. How do we do this better? And how do we do this that it is meaningful and not just tokenism? So these are the onboarding process, because sometimes it's just knowing why it is important, it's not sufficient. We need to overcome that and really kind of get to the how to do this better. So those are our onboarding program. We have a number of seeding grants that are coming up that will help foster more patient-oriented activities. We've got a number of scholarships and fellowships also that are being there. And I'm going to say it up front before you ask the questions. With the design of the funding organization right now, most of these funded scholarships are for academic students or early career investigators, just by the way that the funding is organized. But we are working around the clock to find a way to provide scholarship for patients as well. So stay tuned for that, but it is one of our priorities in working through that. And again, in offering a number of scholarships and fellowship program where trainees, and when we talk trainees, those trainees can be in the academic setting, the clinical, in the community, where all trainees come together and learn together throughout their pathways. Everything is offered in both French and English. Did I forget anything? No? Okay. So look for us. I was going to say, take a picture of our code, but it's not there. But you have our website over there. Don't click on it today, please. It's down to make a few adjustments. So I haven't heard that it was back up today. So maybe wait a day or two before you click on it, but you should be able to find all of the information that you need there. And please do reach out and contact us for any questions, comments, or suggestions.
Great. That was the information part of our workshop. Now we're gonna be interacting a bit more. So again, for those who came in a bit later, I'm Audrey L'Espérance. I'm assistant professor of health service management at a school of public policy, École nationale d'administration publique in Montreal. And I'm gonna move so you can see me. No. That's important. Hi. So today was about to for sure talk about patient engagement globally, because it's a paramount part of POR, of patient-oriented research, but also to think about it with you, because you probably, all of you, experienced or had experience of patient-oriented research in the last years. You might have experienced great partnerships, some partnerships that might have been a bit less great, or even tokenistic in some ways or another. And I was listening to Amy Lang this morning and just thinking that SPOR is 10 years old. And when you're 10 years old, you're not a child anymore, but you're still young, you still need to learn stuff. So we're at this crossroad, I feel, and today is about discussing and thinking together about what's next. So that continuous question, and that's a slide I had for one of my first presentation in 2014 at a SPOR summit, for those who were around. So it looks old, but it's still relevant. And I feel a bit bad of having like the same slide again. And I feel like I connected this morning with the presentation, because like we still get the same questions. We're still stuck with the same things, like waking us up at night. And for me, it's how can we know that we're doing real engagement, real partnership, and not just tokenistically including patients in our research endeavor? And that question is still ongoing today because we didn't end up, really tracking the experiences of partnership across SPOR units and entities across the year. And the reason we didn't is that we actually didn't know what to track for a long time. So I came in 2015 or 14, and that question raised the idea of going into the literature, as all researchers do, and try to figure out what was out there that would tell us how to track, how to monitor, how to evaluate our patient engagement initiatives. And we did a systematic review of evaluation tools. We ended up with really great tools. And it's, there's a toolkit online. It's really nice. But the problem is that we ended up doing this whole work with the SPOR community. SPOR units across Canada were involved in that systematic review. And we ended up with a very fancy toolkit, but no blueprint. We didn't know what to actually look for. And so it's like a carpenter who has tons of tools, but don't really know how to build a house. So we stopped and looked at what we were doing and how we were engaging, and we tried to figure out what the blueprint was. So that idea of creating a framework came in. Again, because we are working on and in partnership with patients and the SPOR community. What we did is that we involved many partners of the SPOR entities in building this. This is a framework that was built over 3 years of work with 3 phases of research, including at the first phase, 43 patient engagement leaders that were identified not by us as a research team, but by all of the SPOR entities. They were asked to identify who actually had a leadership, the champion of their entities, to come and sit and help us identify dimensions to evaluate. And then we did, and you might have participated, to a Delphi, which actually helped us figure out what's underneath all of these elements in the design. So each dimension, we have a list of indicators. So if you look around the room, and you'll see a little later that you can actually go into it. For each element, we actually have a list of indicators that were identified not, again, by us, the research team, but by 100. Actually, there were 89 participants to the 2 phases of the Delphi to identify and bring in the work. And then we worked with a very nice graphic designer. I'm not a graphic designer, and the first version of this framework didn't look like that. But we worked with a graphic designer and patient partners and our community to actually make it easy to understand and use. So this is the Learning Together framework, and that's the product. And I'm going to invite you today to use it as I'd say a reflective tool, a way to kind of navigate the experience of patient engagement, go back on your experiences, go back on what you lived through when you embarked in project, and try to kind of envision the future. And that's just, a tool. It's just a way to, kind of situate ourselves today. But it's, I just think that's a good way also to, have the same language, the same vocabulary. I'm going to just go through the framework with you so you can see what actually came out of all of these, all of the phases that were really collaborative, and everything we've learned through, creating this framework. The first thing we learned is that for most of our collaborators, there are 3 phases of patient engagement and research. The preparation phase, or, building relationships and organizing, to work together. And that needs a little bit of time, a little bit of planning, a little bit of understanding of our context and what we want to do together too. So this is the first part of the path you see. So diverse perspective. Some people will call it recruitment, but I think it's this idea of thinking, what type of experiences, what type of knowledge we want to bring in the work, including, but all patient partners for sure, but also other types of partners, I think. And then what will be our roles? Are there guidelines around that we need to follow institutionally or even nationally? There are some guidelines in your research establishment. Sometimes others are more national in nature. And then build your readiness and co-build your project. That's first phase. And then you go into this round, circle, spiral, wheel, or reel. Depending on who you are, you will all think of different things. Honestly, that's the beauty of how the graphic designer work did, because I really like that idea that we can gather around a circle or around that fountain and kind of work together. And it's not a linear process. It's actually a very much more of a snake and ladder type of thing. You're just, you learn through your process of engaging and partnering together. And in that reel, you can see that it's a muddling through process of recognizing, but also communicating. And maybe you'll be redefining and refining your partnership along the way. And it means very different thing from one project or one team to another. And then the last part is that mountain. And it's funny because Amy had also a mountain in her slides this morning. I was like, yeah, there's something about the mountain in the spore environment for sure. But it's this idea that we're building outcomes one after the other. So actually, what we've learned from our partners and the collaborators and participants in the study is that you cannot actually go and transform care without first building capacities. You won't be, transforming practice without building capacities. So to be evaluating the top of the mountain, you have to actually start from the bottom and actually go and build your outcomes. And that might take time, but it also showed that we needed to make sure that our evaluation eyes or even our planning eyes were on capacity building. So now you see why I work with Annie and PASSERELLE. But this is the last piece. And I just want to put your eyes on the bottom, because that's usually something that people tend to forget. But we ask, from the first phase on, we asked our 43 participants whether the SPORE principles, what you can find in the patient engagement framework, that's the IHR defined in 2014. There are 4 principles in the SPORE framework. We asked them, should we reframe them, change them? Should we add more? Is there something we need to change in terms of principles? And actually, the discussion ended up, we ended up with 7 principles. And I would like to finish presenting the framework to you that way, is that the 7 principles are relationship building, co-building, equity, diversity, and inclusion, support and barrier removal. And I like to underline this because it's not just supporting, it's also lifting barriers for engagement. That takes as much time sometimes. And then transparency, sustainability, and transformation. And I'm again underlining transformation here, because a lot of patient partners, but not only them, during the process, the 3-year process that ended up with this result, told us that they are not engaging just for the sake of engaging. They are engaging to transform. And if we're not building our views and our vision towards that transformation, we might actually not get results or the results we're thinking about. So this is all I wanted to present to you. And again, use it as a tool. But this is something, again, our team learned is that this was supposed to be built for evaluation purposes. But at the end of the day, we ended up thinking that it might be also a good planning tool. And I mean, it makes sense when you think about it to plan and evaluate with the same type of ideas. And so because our exercise today is about envisioning the future, trying to figure out what we should be aiming for next because we're 10 years old, I was thinking that this tool can help us discuss. So Annie, Yvonne, and I, we wanted to actually have a discussion with the group online and in the room about your vision of patient engagement, where we should be heading, and patient engagement globally, including all other partnerships in patient-oriented research. So I'm just going to let you formulate that question for me. It's on your little sheet that actually we distributed when you came in. I saw some of you wrote something already. That's great. I'm just gonna let people just take a minute, look at it online if you want to, take a minute also of looking into it and try to formulate your idea. It doesn't have to be fancy, by the way. It just needs to be straightforward. And so we'll take just a few minutes to think. That's good. Yes?
Could we ask a question now?
Oh, if you want to, yes.
The 7 principles that you outlined out there, it seems like
Well, give me. Sorry.
One thing that I wanted to find out was
Yes.
in the guiding principles, and I think it's all applicable to all presentations done.
Yeah.
Why is accountability omitted on all of them?
Yeah.
Or on your part?
So it's interesting that you ask, because accountability is actually there within transparency. Okay, so when people, when we discussed in groups, what actually emerged was that idea of also evaluation being one way of creating that transparency. Accountability in many ways could create that transparency, and accountability being operationalized in many different things, not just those traditional, more I'd say management-y type of accountability structures like evaluation or more accounting types of accountability, but it could also be about responsibility, social responsibility as well. So we wanted to have principles that would be more encompassing of all of that, and that's the interesting part, is when we're working on the publication and we have definitions or explanation of what those principles mean.
So transparency is to be expanded.
It's expected, yeah.
It's like, for me, it seems like with all, I think all the work that's being done, or I feel anyway, as the messaging is done, is without the patient, or everything that's being put together is for a patient or for a resident or a citizen. So if we are not quite transparent, as you have said, in wording the principles, for example, it might be construed as something is hidden behind it.
It's true.
Because sustainability, for example, that's explicit. You have to be sustainable. That this project has to be funded or has to be managed efficiently.
Yeah.
Kind of thing. So why do we use a word to articulate, a whole bunch of processes that probably everybody should be clear about?
Because, and it's really a good question. So the framework, one fear that came with that work, when we started thinking about doing that blueprint, including the principles, one thing that patient-oriented research partners globally were worried about is this framework that would be too much as a recipe, almost as if there was only one way of doing patient-oriented research, which is not true because all projects are very different because they involve different types of partners. And so it needed to be adaptable as much as possible. So we did a lot of work on trying to do, like we did a lot of qualitative analysis of the discussions, and then we got in the group to think about the words, what the words meant too. I'm just thinking about, we had like, so EDI committees, we have like expert groups of seldom heard communities and spore entities, and we went through and try to see if the vocabulary wasn't also conveying, you know, colonialism or exclusion in a way or another. And so the choice of words came from that work, that process. But it does create a bit of, you know, uncertainty, like or leeway. But I like to see it as a way of redefining for you what those principles mean in your project. And this is something actually that I think is a good reflection to have in a group, just thinking, what does it mean to be transparent? What does it mean to be sustainable for us in what we do? So thanks for your question. It's a good one.
Yeah. And perhaps if you're okay, we would move on to the first activities, but if you do have questions, we'll have opportunities in our group discussions to bring back those principles and reflect on those again.
Yeah.
Well, let's move in, So
to the vision.
Let's move into the visions and some of our activities. Yvonne?
So based on what you've written down, we would love to hear from you because we've done a lot of talking, but really we need to hear from you. So is there anybody who'd like to volunteer? Oh, let's get him a microphone.
Oh, yeah. I'll bring it to you. Okay, great. Thanks. I'll bring it to you. It's just for people online.
Okay, thank you. And I'm trying to frame this question right. So, you know, as a public partner, I've been invited on to sit on research assignments, and it's been very nice. But usually my invitation for dinner is that I should arrive at 7:30 when dinner started at 6. Yeah. So when I'm invited in, I'm sat at the table, and everyone else knows everyone else in the room. I'm the new guy. Not only do I not know the individuals, but I don't know the background of the information. So I don't know how this would work in, you know, who gets tasked with it. But what I would love is for the public and patient partners to be privy to the information as early as possible. And I mean like the deep dive, you know, and I know that oftentimes the researchers are gun shy at actually asking a patient partner to do extra work because there's no money in it, right? So, but I'm this person, I can get through complex situations, but I feel like my hands are tied when I'm sitting in a room and the questions are complex and they're asking me what my input is, and I don't have the answer because I don't know the background. So that's my point. I don't know how to even phrase it into a question, but that's where I am.
So more background information, more like structure.
And
Early.
Yeah,
Early.
All the information earlier.
Yes. Yes.
Yes.
I can follow up.
Yeah, it's very good.
So I wrote down some notes sort of answering the question you're asking there. And, you know, patient, caregiver, and community representatives need to be at all levels of healthcare. Need to be designing research projects and leading research projects, not just added later as you're saying your experience is. And, you know, patient partners and community members need to be embedded in all levels of healthcare, Ministry of Health, policy, design, development, and implementation of healthcare and research right from the beginning, right at all levels, from the top as well as from the bottom.
Thank you for that. Yeah, not just in research, huh? What I understand is like it's the whole ecosystem in a way coming your way.
really hate talking into mics, so feels very weird. So one of the things that's become very apparent to me today is we often talk about equity, diversity, and inclusion, and ensuring we have diverse perspectives. But one of the things I haven't really heard too much about, or like we've kind of like danced around, is this concept of how the current model, especially around not paying patient partners, is inherently exploitative, and it's especially exploitative for people from equity deserving groups. And so when I think about this activity, when it said like what would it look like, to me it's like, can we start to move beyond that? Like, can we compensate and pay folks for their time? Because nobody owes us their like lived experiences, nobody owes us that information. It's a gift that's being provided. And so that's something I'm grappling with. My work for Island Health as a DEI director is, how do we move beyond that exploitative model to something that is sustainable? Because it's just the model in and of itself. And I guess I don't know if that's a question or not, but it was just sort of something I kept reflecting on is, we're asking people to do a lot of work, and what do they get from it? Aside from the contributing and helping and giving to the community. But no, how do we actually show that we value that? So anyways.
I like that. There's two things I hear from what you say. It's like, stop exploitation and start recognition and valuing through compensation, if that's one way. That would be a vision.
I just want to make sure that everybody, in case somebody has joined late or people online, that this is what we're doing is we're really looking at the question, what does patient and public engagement in research look like in, say, 20 or 50 years from now? And we're really sort of envisioning anything that could possibly be. We've removed the barriers, you have the infrastructure, you have everything that you need in order to make it big and possible, and we really just want to see what you think is possible.
Oh, hi. I'm Delia Cooper. And my vision for the future is that everyone in the public who is a patient in the healthcare system and has lived experience will have the option to participate in research. And that we can afford this because our government will reimburse us with credits on our income tax when we participate. And I think that this should happen not just provincially but federally. And if you're participating in research, then you should have a little line somewhere. And of course in BC it's really easy for us to do that because we have reach and we participate. They know when we are either a patient partner or a participant, and it should not divide between the two. If you're doing it, you should get a little bit of a benefit somewhere, and you don't have to have the dollars. You just get it when it comes to income tax.
That's neat.
Do we have any responses online?
Oh, maybe. Any? Yeah, please put anything you want to share with us online.
So we have Sandra, thank you Sandra, who's saying that lived experience has to be valued as a skill and valuable asset in research and healthcare. Patients need to be equal partners on research projects from start to end and compensated.
Other visions? You can think big. It's like 10 years from now.
I guess from what I heard from the panel today is that there's a big burden on individuals to give their feedback, and they're representing like bigger communities, and they're just one person. So I would like to see more patient partners, like a bigger community of them, so that the individuals that do want to contribute have that support and community and are not just one voice, but they can remove that burden and responsibility. So I would like to see even more partners to take it from what I feel is a small scale right now to even bigger, so that the patient partners equal the research team. They equal the number of people or more.
Beautiful vision.
So, from my perspective, we have much of the successful recipe, but what is really missing is the relationship building at the beginning. And I think back to the, I've been involved in more than a dozen projects, and the ones that are the biggest duds are the ones that haven't had any relationship building component to it. And although being face-to-face is important, it's not absolutely essential. I think there are techniques that we can do.
Hear about maybe one that is perhaps contradictory. Is that the right term in English? So how about patient-oriented research does not exist anymore? And it does not exist because it has become the norm, because it is now only research, because there is no other way to do it but to do it this way. We wanted, visions and how we see things in 20, 30 years from now. So
technically I did write that down. I just said that I just said it's status quo and the norm, and not that we're running ourselves out of jobs or anything, no. But following up a little bit on the relationship piece, I think there's opportunity to build relationship that extends beyond project-specific needs. So lots of research is happening in academic institutions and within our health authorities, but if the relationships with the public at large aren't there and aren't strong, then appetite to contribute to specific projects is small. And so I think our organizations that are housing a lot of the research that's happening could do a better job, or there's room for improvement to build stronger relationships with the community, with the public, broadly. So whether it be more opportunity to come and learn around what is happening at the health authority in the research space or elsewhere. I think there's just more opportunity to bring in the public so that when researchers are coming to support units, looking for partnership support, that it's not I have a project and I need this specific perspective to contribute to this specific project, that there are relationships that extend beyond that, and so that it's just kind of creating a different culture that is broader than project to project needs within the institutions and organizations where the research is happening.
I'd like to add my vision. So having researchers that navigate better, or even always good, the tensions of being engaged or of engaging with the public and patients in particular. So having researchers that are at ease with these tensions or can actually navigate them better.
I think we'll move on to the second activity, if that's okay. Yeah. So we just did that. So in thinking about all of these things, all of these visions, all of these ways of being in the research space and beyond, we want to really think about what can we start doing, what can we stop doing, and what can we continue doing. So we're actually going to ask everybody to get up, because we actually have a couple stations around where you can sort of write your ideas. So there's some here, and there's some paper over there. Behind that gentleman, there's some. And we've got markers, sticky notes.
Yeah.
Feel free to write
directly on the paper.
If you find some sticky notes, feel free to use the sticky notes instead.
Use the chat if you if you're online. So what we should start doing, stop doing, or continue doing. Yeah,
Is it
either way.
Yeah, and don't hesitate to share. And there's 1, 2, 3, 4, 5 different boards. So please do come and chat with some of your peers as well as you write those down. And you can, again, you've got markers and you've got sticky notes if you want to write at the same time as others.
You don't look like people that need inspiration, but the framework could be also helpful than thinking about things outside the box. So don't hesitate to look at the leaflets and the drawings. It's great.
But she works in pharmaceuticals. Like, that's her thing.
Well, I mean, we don't have to build it into the budget, so we have like my sponsor, Novartis, or whoever wants to be more patient oriented. They will.
Okay, yeah, no, she's like stuff to like blood to patients and like campaigns and all sorts of things.
I'm the research manager for
Oh, okay, yep. And we might be able to help as well.
Yeah.
But at least kind of, yeah, let's get, yeah, excellent.
There was one on this page.
I know that won't very well. You know, I do that in the summer. Loves the reality. Loves to get the seawall. The weather's good. Yeah, no, no. It's shy away from clouds. So that's clear. I'll do the seawall. Oh yeah, you said, you know, I used to do the entire seawall twice a week. Yeah, it wasn't, you know, I got used to it, you know, like the cool wall. It's down to
Annie, do you still have people online that... I'm going to try to be inclusive and ask what people want online said about starting things. What should we start?
You want me to get started on the starts from our online participants? Okay, so here we go. We have comment from Samira, who's saying that we should start letting patient partner lead research projects and start getting researchers to support the research, be more of a guide or of a moderator to do this work. Then we have another start here. When asking patient partners to come to share their lived experience at conferences, please keep in mind they may be on disability. Paying out of pocket for expenses to be reimbursed can be a stressor. Yes, yes, yes. Patients, and we have the same thing for trainees as well, who have to put money up front when they're traveling. So definitely a major issues. And then it says, I don't know if it's a start, Health Canada should have a place to determine research priorities based on patient caregiver needs. So I don't know if it's a continue or a start. So let's put it maybe in the start until we know the answer. And then again, Sandra says it would be great if CIHR had a registry that could match patient partners and researchers. that is really exciting. Just so that you know, I know that Sport Unit in Saskatchewan have a place to connect patient partners and researchers on projects specific to their province. And there's a number of other platforms that do offer this type of matching opportunities. We could find a way to list them all. I'm taking notes for our PASSERELLE's website.
Well, as this lady here mentioned during your question, in BC, there's Reach BC, so that's an easy one to find. Yeah, it's a great one. It's maybe the best one. I don't know.
I forgot. Apologies, I forgot Reach BC. You're right. Okay, so I think that covers it for online for now.
Good. So we have dollars. So it's probably start funding or compensating. I don't know who wrote dollars. So start, putting money where the mouth is, I think. And then start pressuring our institutions to create an HR category so people can get paid. That's interesting too. So kind of using the institutional structures to also value and compensate patient, listening more. Include POR training in curriculum for new researchers. PASSERELLE, that's like int. Partnering with clinicians to attract possible patient partners. So that was done in Quebec, and it worked quite nicely. Enhance relationship building. Remove barriers to non-academic, fully engaging in research process. AI, so start using AI. Compensation. Start making research partnership normal, expected from every people. Provide more support and training to patient and public partners. Research including patients and public partners early in the process. And then I have down here more training, more grants for relationship building and grant writing. So that's like early grants, even before planning. And then for management and executive, empower staff to work in good ways, expand timelines, temper expectations. That's really true for our public servant partners, very much. So that was start. Yes, but they are continue and stop. So that's why I put them there.
So looking at stop, it kind of, echoes a little bit of what is happening in start in some ways. So looking for public partners later in the stages of the project. Stop bringing patient partners after the ideation phase or ideation or team has been decided. Data dumps, exploitation, tokenism, that happens a lot. Asking the same questions we already have the answers to, over-promising. Another one here is being afraid to take the first step in engaging. So low success rates, concerns for taking time of patients. Eliminating silos. Move away from productivity to meaningfulness and impact. And, I covered some up here. Oh, that's from start. Okay, that's our stop and our continue.
Do you have anything for stop online,
Let's see, Annette. Oh, hi, Annette. We should stop asking for letters of support 4 days before submitting the application. We should stop asking people to give feedback on items in the hands of the REB, which is the Research Ethic Board already. And again, I think it speaks of asking questions and asking for engagement at the moment and at the right time, not as a way as a tokenism. And then, okay, I'll keep for the continue because that's more of a continue than a stop.
Okay, so you want to continue every health projects research project has engaged patient partners. So continue that. That's something that we continue trying. I really like that one because we are trying, and most of us. Continue inclusion, continue SPORE, open discussions. So continue having those hard sometimes discussions, including more patient partners in research. Continue reach, for patient partners. Continue partnering, active listening, and integrated KT. Yes?
There was one thing else I wanted to include, but I didn't know where it fits. But how do we make sure that we are like giving credit where credit is due? I know this is a really common issue within like our public service, is that the names are taken out of things. And obviously, like there's concerns around like anonymity and confidentiality and such. But in certain places and where appropriate, when appropriate, like can we start like putting that out there and giving kudos? Because the other thing I see too is so often patient partners give so much, and that knowledge is, like I said before, exploited and taken and then repurposed, and we're using it, we're taking it as if it's our voice and now selling that, or putting that back out there. So how do we do that? Is it like including their names? Is it including them as a publisher? Like when you publish something, like they should be on that, like their last name should be in there, and like they should get credit for that because they are contributing to it in a way that is so I'm just sort of thinking about that, and I didn't know if we already do that in some ways, and I didn't know if in some ways we don't, but just exploring options to provide that for folks, because it also builds like their like confidence, social capital, like it's contributing to, like it's another way to give back in a sense that like it's not just like paying compensation, right? So they can gain something from it.
Thank you. I don't know if it's start, stop, or I think it's start and continue, because some people or some groups are trying. Yeah, thank you. So, do you have something online?
Online, we just have Annette says, whoever is speaking now, thanks for your comments. And then Annette who said that we should appreciate SPORE and the great results so far, aside from the so many women. And then not sure you should stop anything. I guess if tokenism is used, but I think this whole way of involving patient in research is evolving, and we are all learning how to do it. Grant writing to gain funding is complex. Ideally, patients should be involved even before the grant writing starts and the funding is given. But this is a complex world, and the average person does not know this world. So a relationship needs to be built. So thank you very much. Any additional start, stop, continue that we haven't mentioned? Today is the day to think outside the box and to really say out loud what sometimes we think it may be undoable, but we still need to aim toward to. So
totally. Do you want to go to actions now?
Sure. So the next, go ahead.
Yes. I think our next session is starting session. Yeah, this one is overlapping, so if you need to go to another session, don't worry.
Yeah, that's
that.
So in the second part of this activity, what we're going to do is really take these ideas and make them into actions. So what we want to do is look at, again, start, stop, continue, but for actions. So we're just going to, you can come up again and with your pen and write on there, or again, use the sticky notes.
Oh. Okay, so now so we all came out right, yes, but now we're doing, okay. No, that's fine. Which means that, so they give us all the problems to solve, and we're the one having to fix everything. But that's okay. I think we can do it. So since there's so little.
I thought maybe we would have a little group discussion. We could put these up. And then
Yeah. Yeah, let's do it. Let's do it as a group and thinking about solutions, and then we can write it on the board, because there's not enough of us to actually start doing sticky note.
What are your solutions? Like actions that we can actually take on today? Because there are tons of really great ideas. Sometimes it's, thank you. There are tons of great ideas, but sometimes it's a bit theoretical, and then we don't have like action plans set. So I was wondering if you have actions. There's three of you, yeah. Yeah.
So, for example, relationship building. Like, we hear about this all the time. Relationship building is something we hear about all the time. It's something that we all do. And so when we're saying start relationship building, what does that mean? What do we need to start doing? Or is there something that you do now that is important that maybe all of us should start doing?
I think we need to.
Oh, yes, right.
We need to reach out to a wider community. We need to even outside of healthcare, like this part of partnering with community, and in doing so, you will get more diverse people. You will get more patient partners. You will get more, various members. And so, how do we reach out to community? I'm not sure, but I think that will be one of the ways to move forward. Is reaching out to community more, and we will then, that will be a way to move forward and start improving things.
One of the challenges we have is we don't really have strong community in the health issue that we research. So how do you reach people when there isn't a existing community group that you can go to? There isn't an existing building somewhere where people gather, that, people are connected by this health condition, but they don't have a place to connect. So we've tried to build that for ourselves within our research program. And we've done that in BC, and we've done that a bit nationally and stuff as well. And yeah, we've tried to build that for ourselves, but it's quite challenging to seek community or to build community.
I wonder then if connecting with community also means connecting with community organizations who can help you do that, so that the burden doesn't fully fall towards the research team itself. But if we partner with community organizations, then maybe that's something that they have an expertise in that they can bring to the research space.
We tried that. They were
Okay.
overextended.
Okay, so as well.
They were overextended. So we've developed our own community in BC, and then we've also developed a national grassroots community volunteer-led organization for a national organization and stuff as well. Yeah, that's been, and I mean, that was a lot of relationship building to be able to do those things. But one of the things on there, maybe I wrote it, I don't know, is the grants for relationship building, so that you can actually then develop projects and develop things together. So, some of the collaborating and convening grants that we have, some of the QAS grant at UBC is good for that, but we definitely need a lot more of those.
Okay.
And those that are not necessarily focused on you building a relationship with an existing community, but you building a new community if one doesn't exist.
Right.
Because right now they're all based on you partnering with a community organization.
And I think that Help BC, you do, I don't know if you're within Help BC, but Help BC and Michael's Made do a lot. You have a lot of opportunities in that, and just funding to build relationship, not to build to do projects. So it's really interesting.
Is there something on here that one of the three of you wrote that might be?
I didn't write any sticky
Okay.
notes. I just wrote on my piece of paper.
Oh, okay. Or share from your paper.
Yeah, and if you want to leave it at the end, that would be really much appreciated. I've tried to capture all, but I think we've lost a few of them. Not yet.
Okay. That's all right. So eliminate silos. Where is that on everybody's radar? What can we actually do? What can we do? What's the action behind that?
I think the action is to actually start from the patient experience or the person experience or the community's experience. I think that the only thing that actually breaks silos is to stop thinking inside our organizations and our sectors, but actually start from the experience up and then say, okay, this is what is gathering us in each of our silos. And so this is the common denominator that we can build relationship on. And usually the problem is that, we all stick, I say we as a global we, but we all stick in our organizations with our missions, because we're afraid, because actually going outside silos is also asking to be, it's outside sometimes the scope of our
Asking to
role.
be challenged.
I'm just thinking about you with that idea of building a community. Like as researchers, we weren't trained to do that. That's not like the basic of our training. So now you need to learn new things, do things that were outside, your scope of practice from the get-go. So it's really is offering, great opportunities for innovation, but that can be also super scary. But I think that the common denominator is the community or the patients we want to serve, and that's the way of talking the same language.
Yeah, I really agree with that. And so in the work I do, I started doing local work, then I moved to provincial work, then I moved to national work and international work. And so by that experience, I can bring, if I'm doing local work, I can bring that national, international experience into the projects I'm working on. And when I'm working on a national project, I can bring my local experience to the table and share that. And that's one way of crossing the silos, is as a patient partner, as an advocate, I can take the experience from these different things, because there's quite a lot of silos provincially and federally. And so by doing the work in both those fields, I can do a little bit, at least in my part, to break those silos and try to get that that flow going and that communication and just breaking through it.
Oh, that's awesome. I'm going to go put it out there. But, in thinking about us as researcher, and I think there's a lot to do as well in the academic setting to break those silos, because you get to, I'm not going to, I would want to start from elementary school, and that's all that's me. But thinking just at the university level, as a student, you're within a program, within a faculty, and you have to remain within that faculty. And it's really hard to reach out. And everyone says that we need to do interdisciplinary work, but it's not happening. The system is not made that so that our student can actually learn across faculties with communities, because they have to take classes that are within their program, within their faculty, so how do we break also those silos? Because we need those facilitators at some point also to help the next generation of researchers to embark in that. But it's so hard and so stressful when you get to university. So how do we facilitate that process? Because I think there's a lot that we can help alleviate and remove some of those barriers that we don't even think that this happens. I had a PhD student who did a project across faculties, and people are actually praising her. She says, your thesis could have been in so many different domains. This is amazing. But her evaluator, she got so many reproached that it wasn't specific to her program. and that she needed to do all of those. So, you know, those are systemic not barriers that are there that we don't necessarily, in the community, don't realize that are there. But these are some of the things that students and academics face on a daily basis that we're trying to move past. But that contributes to all of that work in silos, because it's such a huge effort to try to overcome this system.
I was going to say something quite similar. Like, we definitely face that in the work that I do. We're quite interdisciplinary in the research that I do, as we study endometriosis, which is a full body disease and affects many different systems and many different ways of life for people as well. And yeah, we do face that barrier, the academic barrier of kind of forcing you into a silo is difficult, but also the academic barrier of competition. We're very collaborative, and you really have to like humble yourself and say like, well, this is not my area of expertise. I need to bring in somebody and contact somebody who is an expert in that method, an expert in that, you know, experience, and you really have to be like very, very humble, and you have to kind of put aside that, you know, first past the post for publishing type of mentality, and try to work collaboratively internationally as well, if you want to have the big publications and things like that. So, you know, there's a lot of academic barriers that kind of force you into those silos.
Do we have things online?
No.
Okay. So one thing that's on here that is sort of coming up in our conversation is to stop being afraid. So what do we need as you know, as a field of research to stop being afraid?
The more we go into being trained, and I'm speaking as a researcher, the less we are, we get adverse to risk and uncertainty. And I see that in clinicians as well, but I'm not going to speak for them. But I see that the more we get into like the expertise, the less we are aware that uncertainty is still there. And uncertainty in research means that you don't have the control and the full control on all aspects of research. However, that's how we should be writing grants, saying, I have the full control, I know what I'm doing, this is like top-notch research. That's how we're trained to like pitch ideas for grants and build partnerships. But actually the answer, like the real thing underneath is, I don't know, and it will depend on my partners, and it will depend on my co-researchers, because reaching out to people that have expertise in other fields is also not knowing if I'm going to get along with that person, and not knowing if, you know, it's not going to completely derail the research, or and so anyways, there's this, and there's a piece of also not knowing what the results will be. And I found that with the framework work that we've done, I would have liked to try to draw what my vision was at day one and compare it, because now I cannot, you know, show you, but I know that it was like completely different, like, you know, probably the opposite of what you see up front.
Not knowing where either of the folks who identify as researchers themselves are in their career trajectory. I'm not a researcher nor a patient partner. I work with the BC Support Unit, supporting patient and public engagement, so making it happen. But my question is, if you are an early career researcher, your ability to spend extra time making those relationships happen and spend that 2 years getting a little seed grant, you know, have conversations and all that in those first early years of your what is to be a long-term career. Those are valuable years that you're then not publishing. You're not, the currency that your career is dependent on isn't as visible to the more broader research world. You know that it has currency, and you know that it is impactful, and that you know it's going to lead to really good things. But it's in the world of academic and currency and all that kind of stuff, like, how do you convince, not even convince, like, how do you as an early career researcher say, yeah, this is where I'll spend my time for first little bit, and then move into things. Like, we have lots of researchers who are tenured, who have multiple grants, lots of big research programs, who are like, yeah, I can spend 4 years working with a community, no problem, because I'm solid. I'm tenured, I'm good. Whereas our early career researchers are like, gee, can I dip my toe into POR because I want to do a little bit of engagement to say that I'm like learning about it and it's part of my career trajectory and all of that, but I can't spend 3 years doing it. And like our PhD and dissertation folks that we support, we help them dip their toe into it, but they are like, I have to graduate.
And that's the first thing that good advisors are going to tell those students is that don't do a poor project if you want to graduate. Like, they're always going to go into or any type of projects with the community because it's going to take too much time. So, in thinking about the future, and that is something that we talked on a regular basis. So right now, we're the one making those changes. We're the one involved. We're the one that has to make this change, this paradigm change. So hopefully, in 5 years from now, 10 years from now, because everyone's doing poor, then your early career investigators, those relationships are there. Those means, those opportunities, the funding to build those projects are there. So that's what we need to keep speaking up about what is missing and recognizing that it's going to take a bit of time still, but that we can get there. And you're absolutely right that as tenure and full professor, it is our responsibility. So that, I always see my role as that, is that it's my responsibility as tenure to give us many opportunities for our juniors that we can. It's not going to shift, but you're right in that we have to give in. Change doesn't occur if you're being a standby. If you're on standby, you need to be part of that change, and it will require that, and it will require that CIHRs and academic setting. That was our discussion. I don't know if it was this morning or last night. That we need to change those metrics of productivity and change it from papers to meaningful engagement, to impact on care, to impact on patients. So it needs to change. It's not going to be overnight, but we need to keep pushing, and we need to challenge the statu quo. And it's not easy, but I think that that's something that we can achieve, and that it's doable. But you're right in that for the time being, some of those students and early career investigators are penalized. I mean, in 5 years, they're going to see the value of their work, and they're not going to want to change a thing. But right now, they are penalized compared to others in terms of being able to attract more funding because of those delays. So how do we best support them? How does the SPOR units, how do we at PASSERELLE help them with all of these additional grants and support so that they can actually be productive and not worry about that and really focusing on what they're doing?
Sorry, no, I have so many thoughts now. Like, you've run through a bunch of my thoughts, and I've come back around to, well, whose role is it to address these barriers, to take away these barriers? Like, at a conference like this, I don't see, my departmental administrator at UBC attending these conferences. I don't see them here. I don't see the executive directors, attending things like this. And it's the same thing. I was the one who wrote the comment about we need an HR category. We can't pay people. We're trying, but we can't because we don't have an HR category to be able to actually pay people. So we have to do horrible workarounds. And whose role is it? I was hoping that the BC support unit would be a bit more like like a lobbying group. And are you okay? Yeah, we're missing a like an activist lobbying group that targets the people who can actually make those changes in this space.
So in the future of patient engagement, we need a lobbyist group.
Yeah.
That's what we need.
And also
Got it,
something,
okay.
and also something we need is more training in the universities in patient and community engagement. I know UBC is doing some. I don't know about other universities, but it's got to be more embedded in the curriculum. You know, patient engagement, storytelling, relationship building. It's got to be a bigger curriculum focus to move forward.
Yeah,
Not-
go one step deeper than that. What training? What, like in your mind, what kind of training was really going to help people in the future? So relationship building,
Emotional
storytelling,
intelligence.
emotional intelligence.
and how to meaningfully engage with diverse groups, like, you know, DEI training. I'm sure there's some, but there needs to be more. It needs to be part, like, there needs to be that. How do you engage with community in your projects, in your various roles? And so it's got to be like, we have a lot of work out there. We've got a lot of studies we've done. There's guides for meaningful patient engagement that we've created. There's, you know, the Canadian Patient Partner Study that's looked and seen these holes. We take the learnings from those. We take the learnings from some of the work they've done in Denmark in patient engagement. We take the learnings from not only in BC and Canada, but from around the world, and we apply them to our curriculum. And I think we would see another way of breaking through the silos, another way of moving forward with meaningful engagement that is equity, you know, under the lens of equity and yeah.
I'm going to give you context, but once someone asked me to talk to clinician researchers, trainees, about, you know, policy making, and because I'm a political scientist, and I was like, yeah, where do I start? And one thing that came to mind was this idea, because you were talking about emotional, you know, training on what, and I'm just thinking, like, understanding the politics of the field you're in. And it's not about, like, it depends, like, but there's tons of politics around endometriosis. There's just, like, tons of things happening there. You know, and usually patients are very much touched by that. If it's not personally, it's collectively, and just to have that, and also, you know, understanding the politics is also being an active agent in advocating for the community or the patients you work with and for. I guess that's another thing that comes out of evaluation of projects, is that a lot of the researchers say, I didn't expect, but now I'm an advocate for the people I work with, because I need to. Like, I cannot just work for them and with them and then, like, not have a voice publicly about the issues. And just thinking about, you know, the overdose crisis and all this, like that is very flagrant, but like in all aspects of health, there's a bit of politics underneath.
So we probably have time for one more thing.
I just asked online if they had more comments. I'm not seeing anything online.
Compensation, tokenizing.
I love stop data dumps. Stop resource dumps too. Like those websites full of resources, when you click on them, it's not even like up to date or like that. It's like, yeah. I'm sorry, I just saw that. I'm like,
We have 200 resources coming up.
yeah.
But you're right, it's finding the right, it doesn't make it.
No, there are, it's not big. Sometimes it's very useful, but sometimes it's just dumps, you know, lists of stuff, and then you have to navigate in the research.
One point that I'm taking away, because we're really trying to think in terms of What could be some actionable, like actions that we could recommend coming out of this meeting? Before I forget, because we forgot to mention it at the beginning, there's a signing sheet right there. If you want to be part, so we would like to kind of bring all of this into some coherent commentary or something alike. So if you want to be part of this, please leave your we would love for you to be part of this. Leave your name and email, and we'll get back to and sharing kind of what came out of this and see if you're aligned with that. But I heard many comments that we haven't necessarily heard before. And I love the way that you've mentioned it, working at the local, national, and international. I'm also thinking, like, who are the partners that are not part of this discussion yet that should have been, about institutions and leadership in institutions, about what is poor, what needs to change at their level, how we do that, and who's responsible for that. We had CHR has this amazing program for our transition to leadership awardees, and I don't know if you work with some of these fellows. So amazing fellows, which for once they were receiving funding for their early career investigators. Well, guess what? They would come back to us saying, our organizations, our university, our healthcare doesn't have anything to do with us because they don't understand that funding. They think that we're trying to buy. They think that we're trying to buy out our appointment, which is not the case. So, which tells that while it's great to work from bottom up, I think we still need some awareness at leadership positions, and what can we do to help remove some of those barriers, and who should be doing that. And I think that's the questions that you were asking, is who's doing that and how. And then the work in the communities as well. Is it one big community, or is it numerous communities specific to? So I was going to ask more details about your thoughts on that. But when we talked about relationship building, so should we aim more towards kind of that one large community about engagements, or creating more tailored communities in different fields or different areas or different contexts? So I'd love to hear you more about your experience or your thoughts on that.
Yeah, it's great to have a big community, but to have a diverse community, you have to have so many communities. So the trick is, I think, embracing all these smaller communities and not trying to umbrella them all together. So that means that you might have a lot of people at the table sometimes. You might have to reach out to a broader audience in more areas. And I don't know the solution to do that, but I think that as we move forward, we're going to see that we need to expand how we look at communities. And of course, we need to have communities more involved in the policy level. And, for me, it's like infiltrate the government, get up there and, work from the top down. I'm tired of fighting my way up. I'm going to, I want to go from there. So maybe I went a little bit off topic, but it's, we need to really sort of embrace the diverse communities that exist and find a way to support them and be supported by them in the work.
And I'm asking that question because I don't know if you've been asked that question yourself, but I know I've been on a number of programs, like you're building those grants, and then it's always the questions, do we give one big grant, or do we give 100 small grants to build those 100 communities? And that's always kind of that catch-22 questions. Yeah. In terms of more communities but less funding to engage, or one, so that trade-off.
And then again, you have the issue of silos. Mm-hmm. How do you, if you have all, when you have all these communities, then you have the potential for silos. But then if you...
So there are starting to be some grants, like there are team grants that try to break down silos, and there are grants, like the UBC Faculty of Medicine has a grant where you have to have somebody from outside the Faculty of Medicine be a co-investigator with you. So you can kind of, like, if you're talking about like your organization offering grants, you can kind of mandate the vision that you'd like to see a bit, and kind of ask people to come along on your journey with that vision as well.
I wonder if one way to break down silos, engage communities, and build relationships. So let's, I'm going to solve all the problems here. No, but we can do that after this workshop. What if we had patient-led research where really instead of patients coming to the researchers, we had patient and communities, like we had community hubs where they would come up with questions and researchers would go to them. And so it's a different way of doing it. Then like we're getting all the right questions, all the right people are there, they're in the community, and it's actually the researcher who has to approach the community.
Yeah, I'm all for that. I've said that a couple times at the conference already. Yes.
So the community holds the funds.
Yeah.
The community, which again, then you need a community because there's some groups that don't have communities. But ultimately, the community holds the funds, and the researchers apply to be a researcher.
Or researchers become the tool.
One example of that, if I may, if it's along the line of what you're thinking, is that this is what we've done, or we're doing with the Sport Evidence Alliance. So, and that kind of answer the questions of the community, which is, we reach out to patients saying, what do you need? What do you want to know? So patients were the ones sending questions and what they wanted to see and what they wanted to answer. We had up to, I think it was close to 90 different topics that came up. And then they worked in regrouping those topics and seeing if patients would come together and those organizations. And we narrowed down to about 20 or 21 research questions that now you've got those patient-led questions and priorities, which was supported by research, but they all come from patients. And then researchers are going to be matched with patients, and they're going to be helping them do that work, so that it doesn't rely on communities, organizations, and associations, which are overwhelmed already, but rather so it was a way to bringing the patient voice forward, and then being supported. So is that kind of what you had in
Yeah, we applied for that.
Yeah, so in my mind.
But no, we're not one of the groups, but we did apply for that. And that was, again, a bit of a challenge because we don't have a community organization. We have our own own community group that we sort of made up ourselves. But yeah, that's a good, the Sport Evidence Alliance is a good example of a different approach to it.
So my vision for patient engagement in the future is not necessarily even a community hub, but just say a research hub that exists, in downtown Montreal, and anybody, patient or a citizen who wants to ask a research question can, be a member of this hub. And this is where research is sort of started. And, it really, and then you have the tools that come in, then you have the community organizations, and you have the researchers, and they come to this center. And the center isn't at an academic center, it's situated in the city center with people, like people who are actual people.
A citizen science.
But that
that
happened quite. There are a few examples of that also outside the Sport Evidence Alliance, but with, let's say, community organization that started having a role to play in public health and increased role to play with COVID. They have and they see possibilities to do really good research. They don't have necessarily, the people and the leeway, but they see the opportunity.
Mm-hmm.
And when they do have a place to knock on a door and find a researcher, you don't necessarily need to have the funding right on the get-go. And actually, they can actually open up actually the choice for the right venue to get funding. So sometimes it is research grants, but sometimes it is other types of grants that voluntary sector, have more, access experience going and getting. I really like the fact that it just changes and opens up possibilities. But, to come back to fear, that's pretty
always pretty out there.
It's pretty out there. Like, if you're a researcher willing to do that, you're like Evel Knievel of research, like, kind of.
So we are totally over time, but thank you so much for
thank you.
staying and working through this with us. And
was
we'd love
great.
to continue the conversation as well. So please do sign up on the forum if you do want to do that. And thank you so much again.
Thanks.